Dr. Jason Haukoos.
Haukoos.
Pardon me. I was Director of Research and Clinical Research Fellowship for Emergency Medical at Denver Health Medical Center. He's also Associate Professor at University of Colorado, the School of Medicine. And this morning he's going to be talking on applied multivariate modeling in public health. So welcome, Jason.
Thank you very much. Is this a good tone? Perfect. Okay. Well, thank you very much. It's great to be here. It's a pleasure to be here. I talked a couple of times previously at this conference, but it was way back when, 05, 06 region, so it's nice to be back. As was already said, I'm an associate professor. I'm an epidemiologist and health services researcher in addition to my clinical role, which is as an emergency physician in Denver, Colorado. And one of my particular areas of interest centers on prediction modeling, and this is where I came to intersect my academic world with CART, and we'll talk more about that as we go. Just as in terms of disclosures, I'm currently funded by the Agency for Healthcare Research and Quality in terms of an independent scientist award, and I always have to put that disclosure out. And one of my clinical areas of focus historically, so for the last 15 years of my academic career, has been this, HIV. And one of the areas that I work predominantly in is in identifying patients with this infection. And I want to start off and spend about 5 minutes or so just bringing you up to speed, because I suspect that there's a broad swath of people in the room, just bring you up to speed in terms of the epidemiology of HIV in the United States and really frame where I'm going to go in terms of the kind of work I've been doing. HIV is still kind of a rampant epidemic. There's about 1.2 million people in the U.S. infected with it. About 21% or 250,000 individuals in this country have undiagnosed HIV infection. And it turns out that about 56,000, the most current estimates, 56,000 patients or individuals are newly infected annually in the U.S. This translates to an infection rate of 1 infection every 9.5 minutes. This therefore then translates to the concepts here that I want to talk briefly about and kind of how it interconnects with emergency medicine. The numbers of people infected with HIV is growing fastest in racial and ethnic minority socioeconomically disadvantaged patients. These are the same patients who are under or uninsured. Right now we have about 50 million people in the country who are kind of fall into that category. They don't have primary medical care, and they present to emergency departments around the country for their medical care. So it's common that these are the types of patients who present to an ED, and they don't seek care anywhere else. And so the emergency department actually provides a unique opportunity to actually identify these patients. This actually led to our development of the Denver Emergency Department HIV Testing Research Consortium. This is a group, an interdisciplinary group of clinicians, researchers, public health leaders in Denver. In this group I particularly direct, but the primary goal of this group is to bring together people to do clinical health services research to identify the most effective and efficient ways of identifying patients with HIV infection in the department. I hope that's not me. And this relates then to this kind of concept. The earlier you diagnose somebody with HIV, really benefits not only that patient but the public as a whole. Benefits the patients in terms of timely linkage to care, reduced morbidity and mortality because they can be started on effective medications for their disease. And it also helps to reduce their at-risk behavior. From a public health perspective, earlier treatment, decreased viral load, decreases transmission, but it also decreases, hopefully, unscheduled medical care visits and so forth in terms of patients who actually have the disease. And so hopefully it framed this idea around this concept that if you identify patients earlier in the disease course, that you can impact both them and the public. And in doing so, to do that, you can actually target them in emergency departments. And this is sort of where the intersection of my work comes from. In 2006, the CDC released their revised recommendations for HIV testing in healthcare settings. At that point, they called for routine opt-out HIV screening. So they basically said that all patients ages 13 to 64 years should be offered an HIV test using an opt-out mechanism where you basically test them and they have to decline not to be tested. This has been met with some controversy. It's been a very big public health discussion point for the last 5 or so years. And they based it on the concept of this paradigm that I want to introduce to you. This is actually a figure from an article, an editorial that I co-wrote with a couple of my colleagues from about 5 years ago. And it really paints, I think, the picture around HIV testing and what the options are and what you can do. I'm going to actually point you here. So on one end of the spectrum, you can do no testing. On the other end of the spectrum, you can do routine screening. And this actually is what the CDC currently recommends. But in between, you can see that there are a number of different options, and I've underlined the first one. So on the far left-hand side, you can do what's called diagnostic testing.